Good morning. Today I'm going to be speaking about gastroesophageal reflux disease, otherwise known to us as GERD. My name is Savinda Verk, and I am a MSN student in Dr. Professor Big's class. Let's get started. Moving on to slide number 2, GERD. So what exactly is GERD? GERD is or gastroesophageal reflux disease occurs when the amount of gastric juice that is usually in our stomach refluxes back into the esophagus, which is normally known as the food pipe. If it exceeds the normal limit, it causes symptoms that can occur with or without the esophageal mucosal injury. Excuse me. So sometimes your patients will present with, hey, I'm having this constant heartburn, or I'm having regurgitation, dysphagia. Dysphagia is basically I'm having an upset stomach, or there's something burning in my throat at all times. Some of the other symptoms, actually, the patient can present with coughing and wheezing. Why does this coughing and wheezing occur? It occurs because of the aspiration of the gastric contents that come back into the tracheobronchial tree. Or it can also come from the vagal reflux. It causes bronchoconstriction when all that acid rushes back up the food pipe. It's overriding the vagal reflux, and hence that's why the patient can present with coughing. I would know this for a fact. I have a family problem of GERD, and when we eat more spicy food, I am coughing really very, very bad, and I have this burning sensation in my throat as well. Patients can present with hoarseness, sore throat because of that constant acid burning. Otitis media. This was one very interesting fact. Dr. Patti actually mentions this, that GERD is known to cause edema of the uh, mucosal layer of the eustachian tube. So the difference in pressure that is caused by this edema between the middle ear and the nasopharynx is what causes the some of the reflux fluid to go up and settle in the middle ear, hence causing middle ear problems like otitis media. Your patient can also present with non-cardiac related chest pain. This can be due to flatulence, but sometimes when the patient comes in and says, hey, I'm having chest pain, make sure to always keep the differential diagnosis of GERD. Ask all questions pertaining to GERD, as well as if you feel like the patient's is actually having an MI. Enamel erosion is basically very self-explanatory. If you're having acid come back up into your mouth all the time, it's going to hit your enamel and it's going to cause decay. Slide number 3 actually shows a picture of what GERD looks like. You see that acid, the green, the lower esophageal sphincter. You see how it pushes back up, and we're going to talk about the pathophysiology of GERD as well. Let's talk about the anatomy on page number 4. On page number 5, I'll explain it on the picture as well. So on page number 4, here's what we understand. It's very crucial to understand the anatomy of the esophagus if you want to understand what GERD really is. The esophagus is connected all the way from our mouth. It will start in our throat. It basically has 3 different parts: the cervical, the thoracic, and the abdominal. And those actually follow the spine structure as well. The body of the esophagus, the inside is made of inner circular and outer longitudinal muscular layers. They're actually muscle layers, and when they contract, that's what pushes our food down. The proximal third layer is striated muscle, which transitions to smooth muscle by the distal 2/3. Now we know that striated muscle is needed. It's also present in our bladder, where things are needed to expand and then shrink back to normal size. The proximal end is going to have the upper esophageal sphincter, and the distal thoracic esophagus is located on the left side of the midline. So the esophagus is not center stage, it's a little bit shifted towards the midline. When the thoracic esophagus enters the abdomen through the esophageal hiatus in the diaphragm, it becomes the abdominal esophagus. I'll explain it on the picture. It's much more easier to see it on the picture. The hiatus is formed by the right crus of the diaphragm, which forms a sling around the esophagus with the right and left pillars, so that the esophagus narrows when the diaphragm contracts. Really don't understand the role of the diaphragm, and it's not understood by some of the researchers and doctors, but it is noticed that it is crucial to the lower esophageal sphincter, and it causes high pressure. It causes a high pressure zone in the most distal segment of the esophagus, which can be anywhere from 2 to 5 centimeters in length. So this high pressure zone is a remembering fact. It is the pathology of this pressure zone that causes all the problems that we see in GERD. Moving on to slide 5. So slide 5, I found this very nice picture. Actually shows where the esophagus starts, how muscle contraction happens. You see where it says esophagus, that is where the upper sphincter is. And then right about where the stomach is about to start, that is where the lower sphincter is. That pressure that is built between the upper sphincter and the lower sphincter is what helps close these sphincters. It keeps them closed. As you can see, where it shows muscle contraction happens, food flies all the way down, and then another muscle contraction happens. So this is when the diaphragm moves up and down. This is what's occurring during that time. Okay, let's move to slide 6. It feels like I'm rushing, but it's a long presentation. So the physiology, what is going on in a normal digestive tract, or in a normal, when normally digestion occurs? The esophagus, the lower esophageal sphincter, and stomach can be envisioned as a simple plumbing circuit. It's like pressure, water out, pressure, water stops. So that's what we're talking about when you talk about a simple plumbing circuit. So maintenance of an adequate intra-abdominal high pressure zone is crucial in preventing GERD. So if the abdominal area cannot maintain a high pressure zone, the patient's always going to end up having GERD, if not getting worse from there. So the esophagus functions as an antegrade pump, the lower esophageal sphincter as a valve, and the stomach as a reservoir. So just picture this. The stomach is a reservoir that contains all the acid. The lower esophageal sphincter is a valve that opens and closes. So when there's not pressure, that valve is going to relax, and the acid from the reservoir is just going to push up, which we'll talk about in the pathophysiology here in a minute. Proper esophageal clearance is an extremely important factor in preventing mucosal injury. So hence why they say, do not lay down when you're eating, or do not eat and do not be laying down when you're eating, or do not drink when you're laying down as well. You need to properly sit up and give your body a chance to actually push all the food down. And that's why they also say do not lay down 30 minutes, lay down 30 minutes after you eat, 30 minutes to an hour, depending on what you ate. Esophageal clearance must be able to neutralize the acid refluxed through the lower esophageal sphincter. So basically, if the acid is coming up, the esophageal clearance, basically what they're saying is, so what happens is the mechanical clearance is achieved by esophageal peristalsis, chemical clearance is achieved with saliva. So basically the enzymes come in, they break down the food goes down into the stomach, the chyme is produced in which the acid is mixed. This neutralizes the acid at a current point. If it does not get neutralized, where the esophageal clearance comes, that's when there is a burning sensation in the throat. So, normal clearance limits the amount of time the esophagus is exposed to refluxed acid or bile and gastric acid mixtures. The lower esophageal sphincter is defined by manometry as a zone of elevated intraluminal pressure at the esophagogastric junction. For proper LES function, this junction must be located in the abdomen so that diaphragmatic crura can assist the function of LES, thus functioning as an extrinsic sphincter. In addition, the LES must have a normal length and pressure and a normal number of episodes of transient relaxation. So, but in layman's terms, what they're saying is there needs to be a period of relaxation after you eat. If you continuously eat, then the sphincter is basically a valve. Something is passing through it. If it's open all the time, it's just gonna come. It is a muscle. It's gonna relax to that point that, okay, something's always constantly passing through me. That relaxation is what leads to the pathophysiology on slide number 7. So poor esophageal motility decreases clearance of acidic material. So if food is not moving along, not passing along, if you eat too much, you can end up having diarrhea, or you're going to end up having constipation, depending on what type of food you ate. Or if you're not moving around, then there's no motility. The peristalsis halts in your system, shutting down the body to a slower medium, hence decreasing all the motility, causing you to have problems like GERD. A dysfunctional lower esophageal sphincter also allows the reflux of large amounts of gastric juice. So how does this LES become dysfunctional? Let's talk about this. If there's increased pressure, like I said, in the stomach, and there's backup in the intestines where the patient hasn't gone to the bathroom, let's say in a couple of days, or they haven't drank enough water, or if they're not walking around much, there's going to be buildup. When that buildup happens, there's increased pressure. So the stomach relieves that pressure by pushing upwards if it can't push down outwards. Usually would be seen in patients who've had surgery recently, or people who have chronic GERD, people with IBS as well. LES dysfunction occurs via one of several mechanisms: the transient relaxation of the LES, permanent LES relaxation, or transient increase of intra-abdominal pressure. When the defenses of the esophageal mucal resistance fail as a protective mechanism, esophagitis and other complications of reflux disease arise. And let me explain it better on slide number 8, where everybody can visualize and see a picture of it. So, as you can see, food enters, goes through our food pipe or the esophagus. This is the upper esophageal sphincter, where you can see where it says number 2. So that opens for food to pass. It comes down to the hiatus at number 3. And then at number 4, you see the lower esophageal sphincter, and you see the diaphragm. So remember, the role of the diaphragm is not understood, but every time the diaphragm moves, the sphincter opens and closes, as with the passing of the food. So the stomach, number 5, is the reservoir. So in number 4, if that relaxes, or if there's dysfunction of the LES, it is going to cause reflux to go back through number 3 and number 2. When it hits number 2, that's when all the burning and the problems start. Progression of GERD. As you can see on slide number 9, there's the normal LES. The normal lower esophageal sphincter. Do you see how small it is? Do you see that it's very tight? It has a very high pressure zone. Look what happens in the next picture. When a patient has GERD, you see how relaxed it becomes, allowing all that acid to pass up. And look at 2 pictures. One, it can cause esophagitis, where the throat is burning, and then most of these patients do complain of, I woke up in the morning and there was some blood in my mouth, or there's some skin, like dead tissue coming out. When I spit, there's some dead tissue coming out that's tinged with blood. That is a cause of concern, and the patient should always be advised to come see the doctor. And always, this question, if a patient is diagnosed with GERD, this question should always be asked from the patient: have you had any blood? Or do you see any skin, any tissue tearing? GERD can lead to Barrett's esophagus. We all know that. And Barrett's esophagus is very hard to treat. It becomes a chronic condition at that time that can lead to the esophageal adenocarcinoma, which is the fastest growing cancer in the United States and has increased by 500% in the past 30 years. Its mortality rate is at 85%. And it's very well understood that the mortality rate for this is going to be higher, because if you can't eat anything, you're going to go through a rapid decline. GERD can also lead to erosive esophagitis if left untreated, and it can also become a peptic stricture. So if I actually had a patient that came into my psych unit, and we could not figure out what was wrong with the patient. He kept coughing, and he had this runny nose, and he had this very foul smell coming from his mouth. We could just not figure out. His teeth were like they had decay, and we thought maybe it was because of that. But then the family actually told us that the patient had the peptic stricture due to lack of non-compliance with his GERD medications. So everything clicked together, and it was a better understanding, of course. All right, so we're going to talk about some diagnostic tests the NP can do to verify and confirm that the patient actually has GERD. So a medical history is very, very important. Family history. Usually, if somebody along the family line has had it is a genetic problem, but it can also be a lifestyle problem. It's not necessary if my dad had it, I will have it as well. It is basic, but my mom does have this problem, and everybody on her side of the family has the problem, so I think I got the good genes. Physical examination. Always make sure to check the throat, the mucosal layer, the mucosal membranes of the patient to see how much damage has happened already and what you can do. The upper GI endoscopy is actually the best way to find out what is going down the esophagus, how bad the damage is, if there is any damage, or if there is a differential diagnosis to be made here. Barium swallow for those patients who cannot tolerate barium enema. A barium enema actually will highlight the organs that need to be seen under X-ray. I've heard it's a very extremely unpleasant thing to drink, and especially with and then I have had patients tell me that, oh my god, I had the barium enema and I had a barium swallow. That thing is nasty. The biggest thing, a point of concern here, is after your patients had a barium swallow or a barium enema, to make sure that you give them lots and lots of fluid. You encourage fluids if you're in a hospital setting, or if they're going home after the procedure is completed, you tell them to drink water. Barium can cause severe constipation. I also put in a test for a stool test, a urea breath test, and blood work to be completed for anemia and H. pylori, just to make sure that this is for the differential diagnosis, just to make sure that the patient is not having any other symptoms besides GERD, to rule out gastritis caused by H. pylori, basically. In GERD, we know that manometry is mandatory. This is a long word. Esophagogastroduodenoscopy can be done, and ambulatory 24-hour pH monitoring is a must. This is something that can be done in the hospital and has to be done in the hospital while the patient is there. All right, let's move on to slide number 11, which is non-pharmacological treatment. Lifestyle modifications excuse me. Lifestyle modifications are very, very important to treat both diseases like the gastritis and GERD. So losing weight. If the patient is overweight, that is the biggest thing for them to do, to lose some weight. Normal 30-minute exercise every day for 4 days will help them lose a lot of weight. Calorie management is another thing. They need to avoid alcohol, chocolate, citrus juice, tomato-based products, anything that can irritate the lining of the stomach. Peppermint, coffee, and possibly the onion family, which is really placing a lot of restrictions on the patient. But I would advise your patient to start in moderation and slowly but surely delete these things, avoid these things. And advise the patient to have small, frequent meals. If they want to have a piece of chocolate, maybe once in 2-3 weeks. But to make sure that they drink a lot of water and not irritate the esophagus. Should not eat with, if they're about to sleep, nothing by mouth 3 hours before bedtime. And this is the biggest one. We do this in the hospital. We even do it at the psych center. Elevate the head of the bed by 8 inches. This prevents the acid from refluxing back. Avoid any bending or stooping positions. This can cause acid reflux, and it happens most of the time. Your patients will complain of it. If the patient does have gastritis, ask the patient to wash their hands. Keep a sanitary environment, and do not mix different food sources. Always drink water from a safe source. Limit use of NSAIDs. NSAIDs are very, very big. If a patient has GERD, it will cause a gastric bleed because aspirin, ibuprofen, naproxen, COX-2 inhibitors like Celebrex will cause stomach bleeds. They tear through the epithelial layer of the stomach that the acid's not able to tear through. Pharmacological treatment. Antacids like Alka-Seltzer, Maalox, on slide number 12, Melanta, Rolaids, Tums. A lot of these have been used. Just need to monitor the patient and tell them that, hey, if you're going to use something like Tums, anything that has calcium in it, please drink a lot of water. It can cause constipation. If your patient is going to have use H2 blockers, trying to see. Yes. If your patient's going to use magnesium or aluminum salts, these can cause diarrhea. So, and just tell the patient, verify with the patient what they're comfortable taking, and always make your patient a part of the process while educating them, answering their questions, making them feel safe and assured of the treatment plan. First-line agents for practitioners are always H2 blockers like famotidine, Pepsade, cimetidine, ranitidine. There's a study going on about ranitidine not being correct and causing cancer. I have to look that up. I will add to it later. I'll add it as one of the discussion points if I find some information on it. Most of the time, nurse practitioners and physicians usually promote and prescribe proton pump inhibitors because they work more effectively than H2 blockers. They can be available by prescription. Omeprazole is actually available over the counter now, and it is the first-line agent for GERD. It does work effectively, but if it doesn't, the patient can be pushed up to Protonix or Nexium. Sometimes if the patient cannot tolerate that, or if it has gone, Reglan can be used. But Reglan has a lot of other side effects due to which providers don't choose that medication. All right, slide number 13. Education for the patient and family. Advise patient to limit use of alcohol, cigarette smoking. If patient is willing to quit, provide support and medicinal help if needed. If patient is obese, educate on benefits of weight loss program, exercise, and refer to dietitian. Advise patient to stop use of NSAIDs until condition is approved. Teach patient and family of all side effects of medication. Magnesium can lead to diarrhea. Aluminum salt can cause diarrhea. Calcium can cause constipation. Teach a patient to limit these products if no relief after 2 days. After 2 days, patient needs to come in to see the doctor and discuss diagnosis and prognosis, as well as further tests. Always teach the patient to follow the proper medication regimen. Never ever doctor themselves, and never take medication that has without the guidance of a doctor. Always tell to follow up on specialty appointments, especially if they're a GI doctor, and sometimes the patient does need to be referred out if the condition is getting worse. All right. The next slide number 14, is all the references for the pictures and the material. I hope you enjoyed the slideshow. Thank you very much.